invite Dr. Narendra Verma to start his presentation.
Good afternoon, everyone, and thank you, Sapnil, for inviting me for his IC. So, multimodal approach to management of astigmatism during cataract surgery, past and future of the same. So, I have to speak on understanding astigmatism, type and prevalence of astigmatism, diagnostic method for astigmatism assessment. So, I will cover some basic steps or basic things also. So, as a refractive error, astigmatism is of following type, and simple, compound and mixed, all of these are regular astigmatism. So, regular astigmatism is more common. In this, there is bow tie pattern, and the steep axis and flat axis are perpendicular to each other. On the other hand, irregular astigmatism is less common. It may be due to corneal pathology like keratoconus, PMD, corneal injuries or infection like HSB keratitis, corneal surgery like PKP, DALK, delayed keratotomy, and also after post-operative ectasia. So, sometime in the regular astigmatism, there is bow tie pattern, but skewing of the axis. If skewing is up to 20 degree, it is considered as regular astigmatism. So, correction of astigmatism, as you know that regular can be corrected by spectacles, contact lens, refractive surgery, ICL, and during cataract surgery, we can correct the astigmatism by using by implanting toric lens, which is the most accurate best method. And if it is not accessible, then some part of the incision, some part of the astigmatism can be corrected. Some part of the astigmatism can be corrected by the incision on the steep axis. For irregular astigmatism, some part can be corrected by the contact lens, scleral or RGP, or topo-guided refractive surgery. Depending on the topography pattern, astigmatism is of following type. The upper 5 picture in the first row, they are of regular astigmatism type, and lower 2 rows are of irregular astigmatism. As a wavefront, astigmatism is inducing low order aberration, which can be corrected by spectacles. So, this is we are measuring the astigmatism. So, these are different part of astigmatism. So, anterior corneal astigmatism. So, every machine which is doing keratometry will measure the anterior corneal astigmatism. Then there is some posterior corneal astigmatism is also there, and vector summation of anterior and posterior give the total corneal astigmatism. So, when we take any incision on the cornea, when we do surgery, there is some surgically induced astigmatism will be induced, and the vector summation of total with SIA will give you the net corneal astigmatism. This term is commonly used in Barrett toric calculators. So, net corneal astigmatism. So, anterior plus posterior plus SIA is equal to net corneal astigmatism, and if we neutralize this by toric lens, we will get total emmetropia if it is totally neutralized. Depending on the location, anterior corneal astigmatism is of 3 types. With the rule, when the steep axis lie between 60 to 120 degree. Against the rule, when it is 0 to 30 and 150 to 180, and the remaining is oblique. So, posterior corneal astigmatism, it ranges from 0.28 to 0.78 diopter. It is steeper in vertical meridian in majority of the cases, in more than 80% of cases. Its surface is concave, so it acts as a minus lens. Though it is vertically, it is curvature is vertically perpendicular, but it act against the rule. Dr. Douglas Koch, he examined the posterior corneal astigmatism in large number of population, and he gave us this Baylor nomogram, in which you will get the effective IOL position if the astigmatism, anterior corneal astigmatism is with the rule or against the rule, in how much amount and how much will be the IOL power. So, if you can get the IOL power. So, what is the relation between anterior posterior? When anterior corneal astigmatism is with the rule, posterior is in a small amount, but it is there and it is against the rule. So, posterior will decrease the anterior. So, when anterior is with the rule, posterior, which is against the rule, it will decrease the anterior, and total is less, total corneal astigmatism less than the anterior corneal astigmatism. So in these cases, the total corneal astigmatism is less, so we have to undercorrect it. When the anterior corneal astigmatism is against the rule, posterior, which is also against the rule, it will add, and the total corneal astigmatism will be more, so we have to overcorrect it. If you have noticed in your autoref reading, autoref keratometer reading, there is difference in the cylindrical power of the autoref and auto-K. So in this case, in the right eye, autoref reading is 7.5 and auto-K reading is 6.5. So the difference is 1 diopter. This difference is due to posterior corneal astigmatism. There is lenticular also, but it is not, in majority of cases, it is not there. So this is just basic idea that there is something like posterior corneal astigmatism. At present, there is no need to use the Baylor nomogram, because in the toric calculators like Barrett toric calculators, the Barrett nomogram is incorporated, and so there is no need, because if you want to find out the IOL power in with the rule against the rule, it is possible. But you will find out the IOL power by Baylor nomogram in the oblique astigmatism. Lot of mathematical formula you have to use. So there is no need to go for this. You just go in the Barrett toric calculator. The Baylor nomogram is incorporated in it. These are some common instruments which are used for keratometry. So one is manual keratometer, autokeratometer, optical biometers, topographer, and pentacam. Out of these, the newer optical biometers and pentacam, they are measuring the posterior corneal astigmatism also, posterior curvature also. So they will give you total corneal astigmatism. So this is the principle, how they act, and how these are the different type of the keratometers and topographers which are used in measuring the total corneal astigmatism and anterior corneal astigmatism. So manual, previously there was manual, then came the automated auto-K, and then IOL master. So these IOL master, previously they were measuring on the anterior surface, then ORF scan. So they were, when we are putting the slit on the cornea, so we can find out how much will be the thickness of the cornea. So ORF scan, using that principle, they measure the thickness of the cornea, and then they measure the posterior curvature. Then came the same flip technique, pentacam, then Galilei, which is using 2 cameras, so on. Out of these, only Cassini is measuring the anterior surface by Purkinje 1 image and posterior by a Purkinje 1 image. So it is the measuring the anterior and posterior by the Purkinje images. Other are measuring the posterior by the OCT based method, morphological based method. So everyone can't access so much high-end machines, those who are not having high-end machines. So how they can measure and how they can decide whether I should put this toric lens in this patient or not. So there are some, those who are having only manual keratometer and auto-K. So these are some points. So when you can do the toric lens. So you can do toric lens when the astigmatism is regular and your keratometer reading is precise. So how I can achieve it in majority of my cases with basic instrument, if I am having only manual keratometer and auto keratometer. So there are a few suggestions. You have to use 2 instruments, so which are based on different principle. Then keratometry should be done before putting any eye drops or before any contact procedure. 3 identical keratometer readings are considered as reliable. So there should be no difference in the axis. There should be no difference more than 0.5 diopter, 0.1 diopter of the cylindrical power, and keratometry should be done at 2 occasions. So you can repeat on the day of the surgery when you have keep the patient for toric lens in the morning. You can repeat it. Then you have to compare both eyes keratometry. So mainly the steep axis. So what happened? I have shown this case. In this, if you compare the keratometry axis of the anterior surface, in the right eye it is 168, in left eye 8 degree. they are mirror image to each other. If these type of reading is there in this, you can see the keratometer, autokeratometer, the readings are consistently same, axis is linear same. So these type of reading is there, and opposite eye also showing same type of axis, then you are perfectly, there is no need to do topography or examine the patient on higher machines. So you can go in this patient with the toric lens implantation. So in 90% of cases, in the young patient, you will get these type of results. If there is keratoconus or something else is there, then this will not be there. Axis will be different, the readings will be different. Now, what is the aim of toric lens? So toric lens, as we know that net astigmatism consists of, net corneal astigmatism consists of anterior, posterior plus SIA. So toric lens is there to neutralize that net corneal astigmatism. And those who are, sometimes patient can't afford the toric lens, and surgeons, they are not implanting the toric lens, they can correct the astigmatism, or they can reduce the astigmatism by taking incision on the steep axis. So incision on the steep axis, if the incision SIA of your incision is similar to that total corneal astigmatism, you will get the ametropia. So here SIA is decreasing the total corneal astigmatism. In toric lens, whatever net astigmatism, which was including SI also, we were decreasing the net astigmatism. So for the steep axis incision, you have to take incision on the steep axis. So marking of the steep axis is there. Then you have to customize your incision. Size of the incision should be of proper size so that it will induce the SIA, which is equal and opposite to the total corneal astigmatism. And this is the hardest part, that what should be the size of the incision. So for that, we developed this SIA calculator, and it will provide you all these results. It is easy to access. You have just to scan barcode, and you can enter the data in the data sheet, and you will get the results. So it is including the Warren Hill SIA calculator, all the results which you will get from Warren Hill SIA calculator, you will get. An extra polar method is also there. So